Hi, everyone. I am Rachel Werner. Welcome to today's panel. And I am the executive director of Penn's Leonard Davis Institute of Health Economics. I'm really looking forward to today's discussion about the healthcare workforce and specifically the nursing workforce. It's probably not news to you that we have a shortage of nurses in this country, as it's been in the news since the COVID-19 pandemic. And while the pandemic caused the nursing shortage to reach a tipping point, we do not simply have a pandemic-fueled shortage. The nursing shortage began at least a decade ago, driven by a mismatch between the supply of nurses and demand for their work. Demand for nurses has increased with the aging of the US population and other demographic trends. Meanwhile, the supply of nurses is not keeping pace, as nurses are increasingly leaving the profession. The result is open jobs. And then with the pandemic, this shortage acutely worsened. In the past 2 years, 100,000 registered nurses have left the workforce, and over 600,000 nurses say they intend to leave by 2027. We've also seen a surge in the need for traveling nurses to fill these gaps, increases in unionization of nurses, as well as walkouts and strikes. Nurses cite unsafe working environments, understaffing, and unmanageable workloads, and challenges with work-life balances as contributors. The question for today is, how did the labor market become so broken for nurses, and how do we come back from that? I'm thrilled that we're joined by a very smart panel of experts to help us explore these questions. David Benton is the former CEO of both the National Council of State Boards of Nursing and the International Council of Nurses. He is now an adjunct lecturer in the health policy and management at Harvard's Global Nursing Leadership Program. Bianca Frogner is a professor in the Department of Family Medicine in the School of Medicine at the University of Washington, and she is the director of University of Washington's Center for Health Workforce Studies. Gopi Shah Goda is senior fellow at the Stanford Institute for Economic Policy Research and a faculty research fellow in the National Bureau of Economic Research. She recently also served as a senior economist at the White House Council of Economic Advisors. And Karen Lassiter is an associate professor in Penn's School of Nursing in the Center for Health Outcomes and Policy Research. Thank you all for joining me here today. Gopi, I wanted to start with you, and if you could start us off by giving at a pretty high level your perspective as an economist about what is happening with this, the nursing workforce, both quantifying some of the trends in the employment of nurses, but also maybe starting to lay out for us some of the key drivers that we can unpack throughout the conversation. So what do we know about employment of the healthcare sector since the onset of the COVID-19 pandemic?
Yeah, I'd love to do that. So if you look at the data on just the employment in the healthcare sector, we've seen a lot of changes over the last few years. And if we compare just the change in employment since right before the pandemic and kind of look at different parts of the healthcare sector, what we see is that some parts of the healthcare sector have more than rebounded since February 2020, and the employment levels are actually higher than they were prior to the pandemic. These include parts of the healthcare sector, including hospitals, outpatient care centers, home health care services, and physician offices. But there are certain parts of the healthcare sector that haven't been able to keep pace. So two of those are skilled nursing care facilities and elderly care facilities. And in particular, skilled nursing facilities are one of the top 5 sectors that employ registered nurses. And so could be contributing to a lot. It could be a result of a lot of lack of hiring of nurses. Now, I want to state that just because employment has gone up or gone down, it doesn't necessarily tell us about shortages. You know, it could be that demand for nurses or employees in particular sectors has gone down. And so that's why employment has gone down. But there are different ways that economists might think about shortages. So usually economists kind of think about shortages as a short-term phenomena. So if demand is higher than supply, then wages should adjust to draw more people into the profession. And it could be wages, but it could also be non-wage amenities that employees value. So a few other pieces of data, we can see what is happening in terms of job openings. And job openings in the health and social assistance sector were 54% higher in September 2023 relative to February 2020. And this increase is higher than what we saw in the economy overall. So there too, we've seen more job openings, more in general, 36.6% over that same time period. And then the last thing that I'll discuss on this topic is just what has happened to wages then. Are we seeing wages increase for in the healthcare sector? And how does that compare to overall wage increases? So we have seen wages go up by about 20% since February 2020. But we've also seen wages in the overall economy increase by about 18.8%. So wages haven't increased much more in the healthcare sector relative to the rest of the economy, whereas job openings have increased quite substantially more. So I think that's one interesting thing to note.
And so can you maybe tell us a little bit more about your thoughts about that mismatch? I mean, one would think that if there's a demand for nursing that we can't fill with our current wages, that wages would go up. What are your thoughts about why we're having this mismatch?
Yeah, so there are a few different theories that economists have put forward to kind of try to understand why there could be this mismatch between supply and demand. So one set of explanations focuses on just market concentration in the market for nurses. So you can think about if firms have a lot of market power in a particular geographic area, there could be, we could see underpaying of certain professions or underemploying certain professions and posting jobs with lower wages or benefits than you might see otherwise. And so some authors have studied this phenomenon and tried to document whether it is present in in particular in the nursing workforce. And there is some evidence of what economists call monopsony, or this labor market power among employers in the nurse labor market. But the evidence is somewhat mixed. There are also some studies that find results that are consistent with perfect competition. So I don't know that the verdict is super clear on that, but it does seem like there's some evidence that a less competitive labor market could be explaining some of that mismatch. There are two other explanations that I'll discuss briefly. One is this idea of occupational licensing. And so when we think of, and I think we're going to talk more about that later in the hour, so I won't belabor it, but there could be good reasons why we have licensing requirements for different kinds of jobs. This can raise quality, for example, for care recipients, but it could also introduce some barriers for labor supply. And we really need to think about these trade-offs when thinking about certification requirements and other kinds of occupational regulation. The third thing that I'll mention is that this is a market that is heavily driven by reimbursement rates by Medicaid and Medicare. And there's some evidence out there in very high quality research studies that suggest that increases in, say, Medicaid reimbursement rates do seem to be causally related to an increase in the number of skilled nurses per residence. And so that points to one policy lever that could be something to talk about more later in terms of what could actually impact what we think might be a labor supply shortage of nurses.
Right. So low Medicaid reimbursement rates in effect act as a cap on wages for nurses.
Right. It could prevent firms in the healthcare sector from providing higher wages to nurses because the amount that they are reimbursed for additional care provided by these nurses may not reflect the current labor market.
Yeah. Okay. Thanks. That's a really helpful lay of the land. Bianca, I want to turn to you next, and maybe we can zoom in a little bit more. So Gopi's highlighted some of the issues that have led to the workforce shortage. One of the responses to the shortage has been a rise of traveling nurses, as I said in the introduction. I wanted to explore that a little bit with you. Can you give us your perspective about why the use of traveling nurses has been so widespread, and why it's been sustained even at the very high rates that labor or wage rates that were being paid to those nurses?
Yeah, thank you for that question and for having me as part of this conversation. I think one thing is to just mention that travel nurses have been around even before the pandemic, and a lot of times they're leveraged in times of crisis. And in the United States, crises oftentimes have been isolated to certain geographic areas or to certain events. And I think the pandemic was a particularly unique time where suddenly everybody in the country was all struggling with the same crisis, more or less at the same time, with some more concentration earlier on with workforce challenges in urban areas versus rural areas. But generally, travel nurses or travel nursing as a kind of mechanism is usually leveraged in those times of crisis. And when everyone's in a crisis, everyone turned to the travel nurses, all in those agencies, all at the same time, creating this incredibly competitive time for the same pool of labor. Usually during travel, with travel nursing, nurse agencies are pulling from workers across other parts of the country that are not in crisis to bring them to places of crisis. However, when everyone's in a crisis mode at the same time, we're all pulling from the same place, combined with the fact that the US also brings in a lot of nurses internationally, and other countries were also struggling at the same time. Travel agencies basically had a real moment in time where they were trying to respond to everybody's needs at the same time, but they're also businesses. So they were also taking perhaps a little bit of an advantage of the fact that this is an incredibly unique moment in time where they could potentially leverage this competition for nurses that probably led to this particularly high level of wages. But it's not just the agencies. The nurses themselves realized that this provided them an opportunity to perhaps shift their role, maybe try to go to places which were in more of a crisis than others. And they saw that the money was there to make it worthwhile to do. And travel nursing, in terms of how it's been discussed in the media, to some degree is related to and a sign of kind of deeper problems that the nursing workforce has been facing since before the pandemic, where nurses realize, I think I deserve a higher wage. I think I deserve some different kind of configuration of my work my work day. And I think these travel agencies are able to give me and find me those opportunities that meet my needs. And so there was an interesting match of where the travel agents were going around saying, we need nurses to fill in gaps across the country. And the nurses were saying, yeah, you're offering me something that is worth me picking up and leaving, not only because it's probably a good thing to do to try to help other parts of the country, but because I can actually increase my lot in life through better wages, more flexible schedules, and try something new simultaneously. And this then persisted over time. I think as the pandemic has gone on, is that I think nurses have been looking at themselves and saying, I think I like this opportunity where I can get paid more and try something else and have flexibility. And so in some ways it's been sustained. Now, hospitals obviously have struggled during this period of time with travel agencies because of the high wages, and they're paying more than they're accustomed to their nursing workforce. And I think at the beginning of the pandemic, this was something they could do because of the flood of money that came with the provider relief funds and other sources of funds that helped many of our healthcare organizations to kind of weather the storm. But some of those money started to dry up. And I think hospitals in particular said, we don't have the extra funds anymore. And in addition to that, we're just struggling with just kind of getting back to normal. So we can't keep affording these high rates of nursing wages. But if anything, the travel nurse situation has really raised a lot of questions about why is this happening in the first place? Why are nurses attracted to say these places with higher wages. One can't blame a nurse for wanting to make more money. And it maybe points more to kind of problems that might be happening in the workplace that I think hospitals have had to grapple with and are grappling with to figure out how to keep their workforce there. And I think this is a question of, will this be sustained long-term or not? From talking to travel nurses in the field right now, who have been doing it even before the pandemic and some of the work that we're doing, it does sound like the opportunities have dried up considerably, meaning the hospitals are probably closing up opportunities. The money isn't quite there anymore. I know we were talking a little bit before this started today that it's possible that hospitals have been creating their own strategies internally that meet some of the needs for nurses, like creating float opportunities or internal travel agencies. So, it's a difficult situation for us to really get our hands on, in part also because we don't have very good data on this. We really don't have like national data on travel agencies and what's happening there. We don't have detailed hospital data either on workforce to kind of understand what has been happening here. So I think we'll be reading more and unpacking what's been happening in this space for years to come.
Great, thanks. You set up my next question for Karen beautifully, so thank you for that. Karen, I want to take a look, ask you to weigh in on some of the issues that Bianca brought up, which were focused more on the working environments for nursing. And so there are structural factors that are leading to burnout of nurses. And I'll note that the workforce shortage that we're in is not a result of lack of people who have been trained to be nurses, but the result of a shortage of nurses who are willing to work in the field in which they were trained. And so retention of nurses is a very big deal, and the work environments that nurses work in contribute to their retention. So tell us a little bit about the factors driving nurse burnout and attrition.
Yeah, thank you so much for allowing me to be part of this conversation. And I think it's helpful if we start with briefly understanding what burnout is and what it is not. So we know that burnout is a state of emotional exhaustion. It's brought on by prolonged or repeated stress, and it results in depersonalization, cynicism, and a lack of engagement in work. So definitely not something we want from our nurses. Burnout is the result of avoidable occupational stress that's caused by system failures. And it's those system failures that are interfering with the nurse's ability to do their work effectively. It's really important to note that burnout is not the result of individual failings or a lack of resilience. So any interventions that are targeted at the individual level of trying to boost someone's resilience is not an effective strategy to reducing burnout. So if we think about what the driving factors are of nurse burnout, the research is actually very clear on this. The number one factor is unmanageable workloads in the context of poor work environments. It's not the work itself being difficult, but rather it's the organizational failures that are hindering nurses from doing their work effectively that drive nurses to feel burnt out. And the research shows there was a landmark study in 2002 published in JAMA showing that every additional patient a nurse cared for in the hospital setting was associated with a higher odds of that nurse having high burnout. And then in a more recent study, we asked nurses, what would be the most important intervention that your hospital could do to prevent your burnout or reduce your burnout? And the number one thing that the vast majority of nurses said was to improve nurse staffing levels. That rose high above all of the other possible interventions. Other interventions, they said, were things like supporting clinicians to take breaks without interruptions, enabling clinicians to spend more time in direct care with patients. So these things really suggest that nurses are wanting a more relational experience in their work. They want to be with patients delivering care. That's what nurses are trained to do, as opposed to what they're currently experiencing, which is like managing chaos and like just simply trying to keep patients alive while putting out fires in their work environments. We also ask nurses, like, what interventions aren't going to be effective in reducing or preventing your burnout. And they said things that are largely the things we're hearing hospitals are doing. So there's a real mismatch in what hospitals think they should do and what nurses want them to do. So nurses said appointing clinician wellness champions is not effective. Providing resiliency training is not effective. And again, those are interventions that are really targeting the individual as opposed to addressing dysfunctions at the organization level that are putting this undue stress on frontline workers who are being hampered in doing their jobs effectively. So again, if hospitals and other employers of nurses are really serious about addressing the drivers of burnout, they really need to dispense with these ideas of throwing pizza parties and doing resiliency trainings, and instead be responsive to what nurses say they want and need, which is manageable and safe workloads.
So I wanted to just ask you to dig a little deeper on potential solutions that you think could really be effective in improving retention in hospitals, and specifically focusing on structural things that could be done to improve the challenges that you've cited there.
Yeah, so the retention issue is imperative. I saw someone in the chat has already asked the question, is this a shortage of nurses? Like we need to produce more nurses, or is it a kind of a leaky bucket issue where nurses just aren't staying in work? And I would say that the evidence suggests very strongly that it's the latter. We have 4.7 million registered nurses in this country, far more than we've ever had. And there's more and more nurses becoming licensed registered nurses every day. So we're seeing like really exponential growth in the number of nurses, but it's the retention issue that is a significant problem. And we actually just did a study asking nurses who used to work in hospitals but are no longer employed what the major contributing factors were for ending their employment. Planned retirement was the leading reason, which is, a natural loss to the profession that is to be expected. But the next most common reason was burnout. So we need to do something to address burnout, and staffing is probably the biggest, most important issue that nurses say drives their burnout. The second most common thing was insufficient staffing was the reason they left their work, as well as poor work-life balance and unsafe working conditions. So I think it's important to note that wages was an important reason for leaving employment, but it was by no means the leading reason. Wages are certainly important when we think about participation in the labor market, but for nurses, it's not the leading driver. They really want to be working in settings that support and value the work that they do. We also have another study underway that was led by a postdoc, Jane Muir, in the Center for Health Outcomes and Policy Research. And we asked nurses who said they wouldn't recommend their hospital as a place to work to colleagues. So nurses talking to nurses and saying, like, don't come work here. It's a bad place to work. And we asked them why. Why wouldn't you recommend this place? The primary theme there was that this hospital has unmanageable workloads. You're going to have a lot of patients to care for. You're not going to have a lot of support to do it. Other common themes that emerged were things like management is not responsive. When nurses say this is a problem for patient care, administration doesn't listen, and their focus is about money, cutting budgets, and making profits. Nurses also feel like, when I come to work, my license is on the line. So they don't want to work in these environments where they feel like their license is constantly on the line because they're forced to do things that are not safe for patients. And again, wages come up, but they're not the most important thing for nurses when they think about their participation in the labor market.
Okay, that's helpful. Thank you. I have a lot of questions, but I'm going to move on to David now to get you into the conversation. I wanted to ask you, David, about an additional dynamic, the role of licensing, scope of practice, and career progression in adding nurses and aides to the supply of the labor market. And Gopi brought up some of the issues related to scope of practice already. But licensing and scope of practice are largely determined at the state level. And there's a lot of variability across states. With the shifts in nursing education, state licensing rules, and hospital structure, what shifts are needed to support optimal nursing workforce in your view, given the work that you've done across states?
Thank you for that. And there's quite a lot in there. So let me try and just kind of pick it off one piece at a time. And I think one of the things that is important in that question is that you identified not just nurses, but nurses' aides. So starting to think about the continuum of services that need to be offered in terms of providing a service. So it's not just the registered nurse component, but some of the other components as well. And Gopi in her introduction highlighted some of the changing demographics, but one of the demographics that we haven't mentioned up until this point is the generational differences. So some of the things that used to drive me, for example, 40 years ago, where I was expecting to find a career that I would go into, and that would be a career for life. That is not an expectation of many individuals today, and they would expect to change careers on several times throughout their time in service, whatever that service looks like. So the licensing system needs to start to adapt to some of that so that we can make it easier for people to come back into the system if they have left it for a period of time. And that's an untapped resource that we need to be thinking about as part of the process. The other aspect that we need to think about is, and we're getting better at this in the United States, and certainly there are great examples all around the world. And I think one of the things that we need to do is recognize this is not a US problem. This is a global problem that we are now facing, and we actually need to learn from one another in terms of what works and what doesn't work. So in terms of building pathways for a career, so someone might, for example, have had a family tragedy and they didn't do particularly well at school, and therefore they do not have the entry requirements to go into a Bachelor of Nursing program. Let's actually find a way for those individuals to come in as a nurse aide, support worker, etc., and have an articulated pathway that enables them to then progress up through a career, perhaps from a support worker to a licensed practical nurse to a registered nurse to advanced practice, etc. But increasingly, we also need to think about how people move laterally from one discipline to another. Because what we're starting to see, and this is as I kind of move towards some of the scope of practice issues, is that we're actually seeing overlaps between different disciplines in terms of the services that are provided to the patient. And therefore, if someone has got a suite of competencies, what are the pathways to enable them to actually transfer from being a registered nurse to being, for example, a physician's assistant or something akin to that? So we need to start to be much more creative in our workforce models that focus don't just on a name like a nurse or a doctor or a physician, but actually think about the competencies that come with that. And that means that we actually need to be far less precious about the issues of scope of practice. We actually need to say, what is it that the population now need, and who is safe and effective to provide those issues? So we need to revisit issues of scope of practice to enable people to actually optimize what they can. Now, one of the comments you made, or part of the question, you noted that there's significant variation between scopes of practice in different states. That is becoming less and less of an issue. As we've introduced things like the Nurse Licensure Compact, as we have introduced things like the Model Practice Act and rules, what you're starting to see, and those Model Practice Act and rules are now being based on evidence rather than opinion, then what we're starting to see is states actually migrating towards a more standardized approach, which of course makes it somewhat easier for them to move. And again, one of the things that when Bianca was talking about and travel nursing, we were looking at physical mobility. But with technology, and particularly through the times of COVID, we actually saw a massive increase in the provision of services through telehealth services. So the way that we start to plan a workforce for the future is not simply about the local labour market, but it's actually about how that labour market will be deployed potentially more widely through, for example, the Internet of Things. So having a resource that actually interfaces with multiple intensive care units, not just across a state, but potentially across several states. How do we actually workforce plan for some of that as well? And how do we license within that model as well to make sure that the public, if something goes wrong, has got an accountability path to those individuals? So I think those are some of the issues we need to think about. Now, additionally, we also need to think about the educational pathway. And I touched on this earlier in terms of having this articulation between support worker, licensed practical nurse, etc. And we're starting to see that in many states now, but we could go a lot further. We need to have a much more streamlined approach to recognition of prior experience and learning, so that people don't actually just simply say, well, the easiest thing for me to do is to actually just go through the whole program. Well, that carries a cost. And indeed, part of what we also need to look at is whether or not the salary enables you to pay off your student loan debt as part of this as well. So there's another aspect of that we need to think about. A comment that Gopi also touched on was the idea that licensing can be a barrier as part of that process. Well, there is also some research by Beth Redbird from Chicago suggesting that actually licensure is one of the things that can facilitate people getting into the profession, because you know what the minimum standard is. If you've got the minimum standard, you can then get on to the interview schedule, etc. And her work has suggested that it actually can address some of the DEI issues that perhaps have been in place where there hasn't been those standards in place as well. So I think licensure has to play a significant role in re-engineering both the way that people come into the profession, but how they progress through the profession as well, and also accommodate the changes that we're seeing in society, where people will swap jobs several times. And again, part of this is actually about, if you take someone that's let's say in their middle 50s into nursing, and you take someone that's in their 20s into nursing, then actually your projection models actually need to accommodate the fact that the likely life expectancy in employment of those two individuals is actually somewhat quite different. So our workforce models need to be far more sophisticated than they currently are. They are just simply not fit for practice at the moment.
Okay. Anyone else want to jump in on that?
I'll just comment, the scope of practice issue in terms of thinking about who can do what, I think is an important one. I think we tend to say one nurse is one nurse, but one nurse is not just one nurse. Each one has different characteristics. And I think that's a very lost nuance in many of those projection models, for example. But also then as a result, we don't have those important conversations about, well, who else can do some of these activities? I mean, I see a number of questions kind of coming in about like, well, what do we do about the fact that we have this understaffing and we probably can't train our way out of this problem? So what do we do in the meantime? I mean, other than, and retention is certainly a big part of it, is to prevent people from leaving, but we need to then also look at who else is on the healthcare team, because healthcare is a team sport. Who else can maybe fill in some of these roles? But then that's when we get into kind of that tricky area of scope of practice and people saying like, well, but this is my turf and this is my turf, and we don't want somebody to do what I'm doing. And I think that's it's a legitimate concern because people value their education and know how they're educated. But I think what we see a lot in a lot of the studies that we do around conversations around scope of practice is that a lot of other professions don't know what the other professions do. And they're not exactly super knowledgeable about the training that people go through, including how nurses are trained. And nurses are certainly a good example because they're such a large profession and so ubiquitous. However, this happens like between nurses and medical assistants in primary care offices, where we have seen surveys of medical assistants saying like, we're doing the work of RNs, but RNs certainly would say like, look, we have a certain number of training. And so, but rather than saying, oh, RNs, let's fight with the MAs about who can do what, we do need to leverage that conversation to say, well, what else are RNs trained to do that we should be leveraging them so they can take on other activities? I mean, this fight is probably most known between NPs and MDs. I'm not going to go down that path, but this happens over and over again in many different settings. And I think we do need to make sure that when we are deploying nurses, that they are doing what's at the top of their scope of practice. And I'll just add to that I think part of what's underlying some of the burnout of RNs is the fact that a lot of nursing assistants are turning over at really high rates, particularly in hospitals. And so as a result, RNs are finding themselves doing the activities of nursing assistants, and they are saying, this is below my scope of practice. I should not be spending my time doing the things like changing bed sheets, changing bedpans. Like, this is what nursing assistants should do. But when you have such high turnover among nursing assistants, somebody ends up carrying the load, and it's the RNs.
Mm-hmm.
Could I just come back on a couple of points there, and also link something that Gobi said as well? I think one of the areas that is long overdue is actually CMS has not looked at the role of support workers in long stay care for over 2 decades. And the needs of that client group have changed as a result of multiple pathologies, in terms of nuclear families where individuals don't have immediate familial support, etc. And I think one area that could actually help us in terms of a longer term solution to this is to really revisit what it is and how we prepare that entry-level support worker role and standardize that in a way that actually then enables us to actually have that articulated pathway. I think one of the other areas that we actually should not neglect is that many of the barriers that are put in terms of scope of practice are not legislative barriers, but barriers that have been put in via policy within individual employers. So you can have a nurse that is floating between 2 institutions, and they're able to do something in one institution, but they're not allowed to do it in the other because the employment policies in that institution are much more restrictive. And again, we need to have a discussion with the accreditation agencies and with the insurance carriers as well to make sure that we really are able to optimize nurses being able to work at their full scope of practice that they feel competent to do, because that's the other part of it. It's just because we've been trained to do something doesn't necessarily mean that we should be doing it if we're not competent in the process.
Okay. There's a lot of questions coming in, and actually I wanted to, some of them were related to something I think that Karen had said, which was that when surveying nurses about what's causing them to leave the profession, some of it was related to hospitals being understaffed, or not wanting to work at a specific hospital is related to being understaffed. And the question is, there's a variety of different versions of this question, but the one I'll read to you is, how can facilities improve recruitment efforts to bolster staffing outside of offering better compensation? It seems like a vicious cycle. If nurses don't want to work there because there isn't enough staff, how can the facility ever get enough staff to be a desirable place to work? And so I wonder if I'd love to hear from each of you. We talked a little bit about some solutions, including scope of practice, but if you were to think about trying to solve this problem from a hospital administrator's perspective, what would you advise? Because this is a tough one.
I love this question, and I call it a vicious cycle as well, because that's exactly what's happening. Nurses work in bad environments, they leave, they tell other nurses don't go work in that hospital, and it results in the nurses who stay there having even worse working conditions and even lower morale. And so if I were a hospital administrator, I would try and be proactive and in the approach, which is address the issue at its root, and address the reasons why nurses are leaving. Again, I think this is a retention issue. I do not think it's a pipeline issue, and I do not think it has to do with how we are training nurses to enter the workforce. There's also this question looming, which is, how do hospitals afford to pay for more nurses, right? There's the big financial question. And what the research shows is that when nurses are present in more numbers at the bedside, care gets delivered more efficiently. Patients have shorter lengths of stay. so patients get out of the hospital sooner. That's cost savings, serious cost savings for the hospital. Patients are less likely to be readmitted to the hospital. Medicare and other payers are saving big money when patients don't get readmitted. So there's lots of ways in which hospitals stand to financially benefit when they invest in nursing. And also payers like Medicare have a lot of incentive to care about how efficiently nursing care is getting delivered, and that there aren't unnecessary complications in care, that there aren't inefficiencies in care. But if nurses aren't resourced and staffed to do the work they know how to do, these things will happen, and it costs more money in the long run. The other point is that hospitals are spending a ton of money on turnover and replacing new nurses and training nurses. If they had more nurses at the bedside, nurses would be less likely to leave, and they would reduce their costs on turnover. So I think it's really just address the problem at the source, and listen to why nurses are leaving.
Really like to emphasize that point of Karen. I think it's really about having difficult conversations, and I think the easy solution is saying let's just train up more new nurses. But it kind of like I said earlier, a nurse isn't a nurse. Like you can't just replace a retiring nurse with a brand new nurse. They have different years of experience. That by itself makes it just not a one-to-one replacement. So. And that's what makes turnover particularly costly, is not just the cost of trying to find someone to replace the person, but the amount of time and energy it takes to train somebody up and get them up to speed on what's going on in a ward. And those difficult conversations don't have to just be about figuring out how do we raise wages. I think it is about a broader set of things that have monetary value to nurses, such as things like childcare. I mean, let's face it, our health workforce is very female dominated, and many of those women are also the primary caregivers in their homes. So is there something that hospitals can do to support childcare, whether it be help to subsidize childcare, provide childcare on site, things like that? Can they help to subsidize transportation, costs? Like, can they help to make taking the bus or subway lower cost? Can they help to make sure that they're not paying for parking? I mean, these seem like small things, but when you start adding up those costs, they have real wage consequences. And I think sometimes it feels kind of impossible to address the wages, but there might be some things that hospitals can do as major organizations, or medical systems can do as major organizations, to implement some of these strategies that are maybe more within their control, maybe things that they can do within their revenue cycles, and also figure out how to work with other hospitals on these larger issues that are kind of more policy oriented. So maybe working with their Chamber of Commerce and saying, like, we need to now figure out how to advocate for childcare subsidies in our county, in our state, in our city. So going beyond their walls to say there are policy issues at these different levels that can help get them the resources they need, that is beyond going to Medicare, CMS to negotiate wages.
So I have three thoughts. Two of them actually are from when I was working as the director of nursing of an integrated healthcare system in Scotland. The point that Bianca made earlier about travel nurses, the flexibility is something that they value. One of the things that I did was I rewrote Dr. Johnson's book on Who Moved My Cheese, and I focused it on flexible working practices, identifying 25 different types of flexible working that were available, used the organization to identify who had had success with all of those, and then open that up to enable people that were out of practice to come back in because they had young family or older parents that they had to look at, and they couldn't make a commitment to a full-time job, but they wanted to have a couple of days of work that would enable them to do that. So I think we can be far more flexible in our employment practices, and we can use existing success to drive a more open environment. As a result of that, we were actually able to save money because we did have bank and agency work coming in, and I did a deal with the director of finance to say anything I save, I keep half of it and reinvest it in nursing, and the other half I'll actually give to the middle, the kind of general pot. And we were able to increase the staffing numbers as a result of actually bringing flexible working into the environment. The second thing we did was actually really focus on return to practice. I was a policy advisor to the minister in Scotland at the time, and we got him to agree to provide some funding to support return to practice. In Grampian, NHS Grampian, which covers about 5% of the population of the whole of Scotland, we actually were able to return 80% of the nurses because we designed the return to practice around their needs. We didn't simply say, well, if you want to return to practice, you've got to come to this big institution in the capital city or whatever, etc. So I think return to practice programs is another mechanism. And finally, the point I would make is, we really have to start to value nursing, and we need to do that instead of actually charging for nurses as a part of room and board, but actually to assess what the value-added contribution is. So having a standard unique identifier which enables you to track the contribution of the nurse through the entire system will actually enable us to get a much better understanding of just how valuable nurses are, and what we need to do to actually get them into play as part of that.
So I'm struck by this conversation about how much we've heard about how, you know, hospitals benefit a lot from taking care of their nursing workforce, and it results in better outcomes for patients as well. And to me, that question that raises is why then are, you know, hospital administrators not actually investing more in this workforce and doing a lot of the things that we've been talking about? And I think we need to understand what those barriers are. And if it turns out that there are some market failures here that we need to correct with government policy, then we need to identify those. I mean, you know, just one thought is, you know, not just implementing, say, minimum staffing requirements, but maybe having some financial incentives for, you know, healthcare employers to have appropriate staffing requirements could be one way that government and policy could intervene if there are some issues that are preventing hospital administrators from doing all the things that we've been talking about.
And I will say this is probably where strikes are coming in. I mean, it's just a signal that like there is a bit of a market failure. And so, and right now it is probably, power is probably more on the side of employees right now, because they do have, and on the nurses among those employees. So I say employees because broadly, this is not just happening in healthcare. This is happening across the board. We see strikes happening in many sectors of the economy. And it is a sign that workers have a little bit more power right now because they have lots of opportunities. And so this is the time for them to get to the table and say, okay, we need to fix some of these problems. And I think the travel nursing is, again, kind of a more of a symptom of a larger problem, and that, you know, travel agencies kind of were the de facto negotiator for a bulk of nurses for this period of time during the pandemic, but they're not really situated to be the long-term negotiator to set up kind of broader workplace changes. And that's where unions are coming in, and they're saying, okay, that is their role to help negotiate better terms of the agreement. And this is the time for nurses to go to unions or work with unions to advocate for the things that they need on their behalf. And to push the hospitals to say we need these changes. And, you know, I would say medical systems, hospitals are coming to the table. I think with Kaiser Permanente as kind of being an example, is that they did come to an agreement. I don't think it's been fully signed yet, but at least it sounds like an agreement has been reached. And that's a good sign that it's probably, we would prefer hospitals just to make these changes, but at least when their hands are forced, okay, they're able to come to the table and make a change. I mean, I guess I go back to, again, to say, I get that hospitals are probably struggling financially still as they still kind of come out of this pandemic. But I think that the burden should not be borne by the employees. the burden should probably go back, as I think Gopi is alluding to, back to probably the federal government or the state government, who need to help to step in to help fill in the gaps financially, or to help figure out what are the mechanisms that need to be done structurally to make supporting workers more sustainable.
I also think there's a point to be made here that there's an opportunity to have greater transparency and accountability on the behalf of hospitals about where the money is going and how it's being used. An enormous amount of money flows through hospitals and other healthcare systems, and we don't have good outcomes and good quality to show for it. And nurses, who are the sort of reason that patients go to hospitals, if you could get your surgery outpatient, you wouldn't go to a hospital. If it could be in a doctor's office, it wouldn't be in a hospital. But the reason you're in a hospital is because you need nursing care. And so if hospitals aren't investing in their nursing care, what then are they doing, and where is that money going? I think there's an opportunity to have greater accountability about how hospitals are investing their money and where it's going, if not to nursing.
And and I realize that we tend to, in this conversation, we talk about nurses in the hospitals, and that certainly is one of the largest employment settings for hospitals. But I do want to point out David's point about long-term care. I mean, that, especially skilled nursing facilities, we have not paid enough attention to what's happening in long-term care. I think this year, if any year, I feel the most hopeful, seeing how much activity there has been on the Hill around long-term care. And my understanding is that perhaps there'll be continued conversation in this area. But there is this question of not just like, why aren't hospitals doing something, but why aren't policymakers doing more? And I often reflect on this past few years, like what did we learn or gain out of this pandemic? Did we learn anything? And are we changing anything? And I think most people in the room would say, not really. And I think in long-term care, that's been particularly surprising, given just what a mess, I would say, it just has been in that area throughout the pandemic. And there's so many challenges that certainly you all have had separate conversations around long-term care through LDI's these webinars. But I think part of it is this question of like political will. Where is the political will to make some of the changes happen? And like, what is the story that we need to be telling to get there? And I have to say, I'm a little puzzled.
You're not alone in being puzzled. Thank you for bringing that up. I was actually about to ask about long-term care, because everything you describe in hospitals, I would say, is worse in long-term care right now. And it's interesting, Karen, you were talking about where does the money flow? Like in long-term care, God only knows where the money is flowing.
And I would say that's the one area that there's some more data, at least. And if anything, that is the one area I do really appreciate, that like CMS is making a real effort to try to collect data, put it out there, get it out there on more of a real-time basis. And we could probably benefit from that across more settings in the healthcare setting.
Absolutely. Okay. Well, you guys have been great. This has been a super interesting conversation. We only have 8 minutes left. And a lot of the questions we're getting in the chat align with the last question I wanted to ask you, which is about what do we do next? So we've talked about just now the COVID pandemic potentially providing a window of opportunity to address many of the shortfalls we have in healthcare, including the workforce shortages. And I wanted to ask you, particularly in the setting of a real interest and investment in trying to address workforce issues, and there seems to be bipartisan support to do something about it. A two-part question. First, if there was one state or federal policy change that you think would meaningfully address the nursing workforce shortage or fix the labor market, or start to fix the labor market, what would that be? And the second is, how optimistic are you that change might happen? And so we have just a couple of minutes for each of you to answer that question. Does somebody want to volunteer to go first?
I'm happy to kick off. So my policy change would be either state or federal requirements for minimum safe staffing in hospitals. I'm pretty optimistic about this for a number of reasons. There are more and more states pushing for this legislation. For those of us here in Pennsylvania, you should know that it's passed in the House for the first time ever. And it's on its way to the Senate. It's called the Patient Safety Act, and it would require hospitals to staff enough nurses to safely care for patients. The only state in the country to have this kind of legislation is California. It's had it for 2 decades now, to good effect. Patients in California get 3 more hours of nursing care a day compared to patients in other states. And Oregon will be joining in that this summer. So I have optimism that we're moving in the right direction. Also, the American Nurse Association has endorsed this legislation at a federal level for the first time in a long time, which represents a major historic shift on their position. And the last thing I'll say about it is I'm optimistic because I know that the public knows how important nurses are in patient care. And they understand now more than ever, I think, because of the pandemic, that if we don't have nurses at the bedside, public health is going to suffer.
Great, thanks. Gopi?
I would love to add on to what Karen said in terms of increasing or, changing minimum staffing ratios, but maybe perhaps also tied with some kind of funding source for that, so increasing Medicaid reimbursement rates or having some kind of dedicated financial incentives to help companies and hospitals do that, I think could make that even more effective. Because I think we all know that sometimes, these unfunded mandates are hard to fill, especially in the current environment of, staffing shortages more generally, or labor shortages in the economy more generally. And I'll just add one more thing, which is if we're thinking long term, the evidence on immigration, increasing immigration flows, is also very convincing that this could, effectively lead to more both RN and CNA hours per, say, nursing home resident in different areas that have seen higher rates of immigration flows. And so it's not an immediate fix, but it's something that could potentially, help in the long run. But I'm very sympathetic to David's point earlier that this is a global issue. And so, increasing immigration in the US is not going to solve this overall problem. It's really just shifting things around. So
Do you have a level of optimism?
I'm pretty optimistic on the staffing ratios, like Karen said. But, I don't know if people are really having the conversations of where the funding is going to come from.
Those are hard conversations.
So for me, it's about a long-term solution. We actually know what the long-term problems are going to be. If you look at the 2050 predictions for the numbers of individuals we have and the age bands that they will be in, then the current model is simply not sustainable. The population support ratio is going to halve in the next 20 years, and therefore the competition for workers within the health sector is going to become even more acute. So we're going to have to actually fundamentally rethink the way that we deliver care and the way that we educate practitioners in a way that actually enables us to optimize the usage of the population that we've got. We know that the Midwest is actually going to hit a problem before either of the coasts, because our health system kind of pulls, or at least our education system pulls people away from rural communities into big population centres, and actually sustaining the health and well-being of these centres is going to be increasingly more complex. So we're going to have to look for solutions that other countries that have faced this problem for some time have started to use, using technology where increased monitoring at a distance can take place, so individuals can actually prioritize their visits as part of that process, and using technology that will alert us when things start to go wrong. So earlier intervention on some of these issues. We know that the US and many other countries have got huge obesity problems, and that is actually adding to the long-term labor burden that there will be within the health service. So there are many things that policymakers could do, but they've got to stop using a band-aid solution that actually is only thinking about their next election cycle and actually thinking about the health and well-being of citizens into the future.
So I'll try to say, I think we know a lot of the solutions already out there, and somehow we need to get the political will to do it. And there are a number of bills on the Hill, and somehow we need to get those moved forward. So it makes me think more that there's probably an approach that we need, which is to figure out how to leverage the voice of the actual workers themselves. And what maybe that's part of the educational sector's role here. Maybe this is where professional organizations can play a role, that they can help to train workers to do the work of helping with lobbying and advocating for their needs. It may not be the perfect solution, but it's at least one way to do it. And it's to think about how to also get nurses the tools that they need to also take advantage of new technologies coming out like ChatGPT, and hearing from them about ways that we can leverage and harness this new technology to make their lives easier. I hate to put it back on the nurse, but I think that nurses are such a large occupational group. They have such power. People are listening. They care about them. So this is their time and their moment. So we need to equip them with the tools that they need to be effective advocates.
Great. Well, thank you. And thank you for the great conversation. I've really learned a lot, and I think I leave this conversation with some amount of optimism. So thank you for providing that as well. Thanks to the audience for your active participation in this. And I wanted to just let you know that we have an upcoming seminar, which is about artificial intelligence, which just started to come up at the end of this conversation. So do no harm, balancing innovation and regulation for healthcare AI. Please join us for that. And thanks again for joining us today. And I hope everyone enjoys the rest of December. Take care.